In this chapter, we're dealing with the C in our ABCs, circulation, and the focus is shock. Now, ATLS is not a critical care fellowship, so it won't teach you all the fine points and details of pathophysiology. Instead, it aims to give you the basics you need to handle a trauma patient in shock successfully. Remember from chapters 1 and 2 that your goal is adequate perfusion of well-oxygenated blood. So with shock, we're talking about inadequate end organ perfusion and tissue oxygenation. In other words, in shock, the delivery of oxygen and nutrients to tissues is inadequate to maintain minimum normal cellular function. Let's take a look at another patient. A 40-year-old woman, while skydiving to celebrate her birthday, misses the landing zone. Her parachute gets tangled in a tree. A limb breaks and she falls 30 feet to the ground. She is brought to the ED, screaming in pain and states it hurts all over. No obvious deformities. Heart rate 140, respirations 30, BP 95/63, GCS 13. EMS has started an IV and placed a C-collar. Using MIST, we get the following breakdown. Mechanism: 40-year-old female fell from a tree. Injury: no obvious deformities. Signs: heart rate 140, respirations 30, BP 95/63, GCS 13. Treatment: 1 IV and a C-collar. It should be clear to you that this patient is in shock from her tachycardia, tachypnea, and hypotension. However, it will not always be so obvious that the patient is in shock. And even if it is obvious, it is still easy to get distracted by impressive and dramatic injuries. In Chapter 2, I emphasized being able to recognize early that you have a problem. This is key to managing the trauma patient. Then, you need to identify the causes or potential causes of shock as fast as possible. And to do that, you need to answer these 2 questions. Number 1, what's killing her now? That's right now, immediately. Number 2, what's going to kill her later? That may be in the next 10 minutes or in the next hour. Although resuscitation starts even before you have a definitive diagnosis, you need to address both of these questions along with and as part of your efforts to resuscitate the patient. Otherwise, you might as well just pour the saline, LR, blood, FFP, platelets, and whatever else you have running right on the floor. As I said in Chapter 1, volume, 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 and stop the bleeding. They go hand in hand. Hemorrhagic shock is the main cause of shock in trauma patients most of the time. Therefore, if you have a patient in shock, in general, the question is, where is she bleeding? Even though hemorrhagic shock is the cause of shock most of the time, it's not the cause all of the time. For those situations, you need to consider a non-hemorrhagic cause of shock, like neurogenic or cardiogenic shock. I'll talk about those a little later in the video. Septic shock is also a possibility, but it's rare in the trauma patient. So with all that in mind, assume your patient is in hemorrhagic shock and treat her accordingly until you prove otherwise.